Hello, everyone, and welcome to this episode of Criminal Mischief, the Art and Science of Crime Fiction. I'm your host, DP Lyle. Uh, Today, I want to talk about actually cardiac surgery during World War II. It comes from a question that I received from a writer, and I like this because it's historical fiction, because it's about a character, and because it is about medicine and particularly cardiology, which is my field. So it hits on all the points. So the question is, I write a mystery series set during the Second World War. My question is about heart surgery during that time period. I am planning a future book in which my character's heart ailment catches up with him and he undergoes surgery. What specific ailment can he have? And it needs to be something that he can have lived with until his 20s and then becomes critical. It's also something that could be repaired by new surgical techniques around 1944. Plus, he needs to have a fairly quick recovery so he's not out of commission too long. Okay, this is great storytelling, and I love this stuff. I love to help people figure out their stories and what works and what doesn't work. What are the options here? Well, first of all, there wasn't much cardiac surgery in 1944, as in like there was none. The first real surgery probably came along about 1955, and it was to repair a congenital heart problem called tetralogy of Fallot. Now, these kids did not live very long, maybe to age 20 or so, and many of them died in their early teens. Um, so it was a congenital problem that was the first thing that was repaired, and it could be done without going on the heart lung bypass machine, which didn't exist until a little bit later. So this was done by it's called the Blaylock-Taussig procedure, and it was done at Johns Hopkins by Dr. Blaylock and Helen Taussig, who is a pediatrician there, designed the repair of this. But before that, you didn't touch the heart. I mean, that was a no-go zone as far as surgeons were concerned. You just didn't touch the machine. You didn't touch the engine. Uh, there was no technique to do it. There was no way to do it, with a couple of exceptions. So, in thinking about this, what could this character have that they lived till their 20s and then they started having trouble, and then during the World War II time frame, something was done to make it better so that they could move on. Um, the congenital problems like tetralogy of Fallot and like transposition of the great vessels and all these things, these complex congenital problems wouldn't work because, first of all, most of them died young. And second of all, there was no way to deal with them. But there is something. And my suggestion to the writer was mitral stenosis. Now, what the heck does that mean? Well, mitral stenosis is a narrowing of the valve that's between the upper and lower chambers of the left side of the heart. Now here you can see this is a normal heart, and to reiterate what you probably learned in high school biology, the right side of the heart's represented in blue, the red side in red. Well, that's because this is the oxygenated side and this is the unoxygenated side. So you see blood comes into the right side of the heart from the superior vena cava here for the upper part of the body and the inferior vena cava for the lower part of the body into the right atrium. It crosses this valve, which is a one-way door, opens and closes in only one direction, called the tricuspid valve, and it goes into the right ventricle. From there, it's pumped out and goes to the pulmonic valve into the pulmonary artery and out to the lungs. Great. So now this blood that's been, all the oxygen has been sucked out of by the cells of the body, go into the lungs and they pick up oxygen again. Now they return through these called the pulmonary veins. There's two on each side. The others over here aren't represented. They come into the left atrium. From the left atrium, they go through this valve called the mitral valve into the left ventricle. And when the left ventricle squeezes, it slams these doors closed and it opens these doors, again, one way doors in both cases, the aortic valve out to the aorta and through the entire body. So the valve that we're concerned with right here is the mitral valve. Okay. So it's the mitral valve is where the issue takes place. Now let's see if we can show a picture of a normal mitral valve. This is an echocardiogram, a sound wave motion picture. I think yeah, this should be a normal mitral valve. Is this the one? No, it's not. Let me go back to the one that it is. A okay. This is a normal mitral valve, and it should if you watch this, it will show you this is what we saw before. This is the left atrium. This is the left ventricle, and this is the aorta. And right here is the valve that is in question. And you can see it. That's not the right video. Sorry, guys. That's not the right video. I wish they wouldn't do this to me. Oh, maybe I'm doing it to myself. Is that what you're trying to say? I'm trying to show you the normal one. Well, the videos aren't going to work very well. So let's go back to this. The mitral valve is the one that is in question, and you can see this is a nice wide open valve, so the blood comes to the atrium, flows right through the valve into the left ventricle and out. This is a nice thin valve with wide open, so the blood flows through. When you get mitral stenosis, the valve goes from a nice opening, which is a two-doored valve, to something that is scarred and narrowed and nasty. And you see that represented with the thickened leaflets. And this restricts blood flow into the left ventricle and therefore the amount of blood that goes out to the heart. And so the symptoms of this are fatigue, weight loss, shortness of breath, inability to exercise, and in its severest form, it can cause pulmonary edema, which is the filling of the lungs with water. The reason for that is quite simple. As the blood is trying to flow across that diseased mitral valve, the pressure back here must build up to force the blood through. An example is open your mouth, take in a breath, and then exhale. Very easy to do. No problem. Now purse your lips when you exhale and make them very tight. And the tighter you make your lips, the more force it requires for you to exhale. This is the same thing. The more narrow that this valve gets, the more pressure it requires to push the blood through it into the pumping chamber so it can get out to the body. Well, this raises the pressure back through the pulmonary veins and into the lung circuitry itself. And this causes fluid to leak out into the lung tissue, and we call that pulmonary edema. Pulmonary is for lung, and edema means water. And this can be very dangerous and very deadly situation, particularly in mitral stenosis, because it is a mechanical issue that can't be fixed. So this individual would have developed this problem, and by his 20s or 30s, he would start having symptoms, and they would say, whoa, there's something wrong here. Well, okay, that's great. What are you going to do now? First of all, let's talk about mitral stenosis. Where does this come from? Well, the overwhelming majority of cases of mitral stenosis are caused by rheumatic fever. Now, rheumatic fever is an infectious disease that is caused by a streptococcus. Now, interestingly, there's millions of different strains of streptococci, and you know them because you've had a strep throat probably. But only about 6 of those can cause rheumatic fever. And the way they do that is that these 6 cause an immunologic reaction within the body. It builds antibodies. And somehow these antibodies cross-react with the tissues of the valves of the heart. and they cause inflammation and scarring of those valves. By far, the mitral valve is the one that has attacked the most, then the aortic valve, and then after that, the valves on the right side of the heart. So you can have all four valves involved in this, but almost never do you get it without the mitral valve being involved. And when it scars down, it doesn't open and close properly. It becomes thick. And instead of being nice and fluid, the valve doing this, it's doing that. And it's thick and it's scarred and it doesn't work. And so, like I showed you, it slows the flow across the valve. Well, we don't see that much anymore. And there's a very simple reason. A dose of penicillin will kill streptococci in a New York minute. Bang, gone, done. From the 1950s on, every time a kid got the sniffles, he got his butt popped with penicillin or he took penicillin tablets. But penicillin didn't come into existence till the 1930s, and it wasn't really widespread out to the medical public until the 1950s. So, was it available in World War II? Yes, it was. But remember, this guy is going to be in his 20s. Let's say 24 in 1944. What does that mean? He was born in 1920. And that means when he was 5 years old, he had a bout of rheumatic fever. So that would have been 1925. There was no penicillin around. And how would he know he had rheumatic fever? Well, he may not have, and most people didn't. They get what we call minor symptoms or what we call a subclinical infection, meaning that you're not sick enough or you don't recognize the symptoms enough to say, oh, I know what that is. Now, full-blown rheumatic fever, you have a sore throat and high temperatures, and you have a skin rash, and you may have joint aches and pains and things like that. But that's the minority of cases. Most are like a strep throat. You get a sore throat for a few days, then it goes away. Or you have no symptoms at all, maybe a day of fatigue, maybe nothing. But the disease, the process, the streptococci have populated the nasopharynx, the back of the mouth, and they have set off this immunologic reaction. Now, this immunologic reaction slowly, year after year, decade after decade, chews on the valves. So by the time this kid is 24 years old in 1944, he could be in his unit and start complaining of fatigue and shortness of breath, and he could even have a bout of pulmonary edema. But the bottom line is that they know he's not well, and they know he cannot keep up with his duties, that he cannot run around with his backpack on, that he's not combat ready. And so now they get him checked out, and they find he's got mitral stenosis. Okay, what are they going to do about it? And now we can replace those valves. We can even replace those valves through catheters. They call TAVR procedures or TMVRs for the mitral valve. And basically they put a catheter up in there in a balloon and open the valve. And the next thing you know, they put a valve in. Then this is current time. In the 1980s, they came along with what's called balloon valvuloplasty. And this is where they use a balloon to open up the artery. And if you look here and see, this are fluoroscopic images of a balloon valvuloplasty. So the mitral valve sits right here where that little indention is. And so the catheter goes in and the balloon is passed across the valve, and then the balloon is blown up. And you can see the little indention of the valve. And now you see the balloon is filled more. And now the balloon is filled, and this little waste is the valve. And then finally you add enough pressure, boom, it cracks the valve open. You deflate the balloon, you pull all this stuff out, and guess what? You fixed it. The mitral valve that was diseased and shrunk down, and stenosis is our word for narrowing, has suddenly by a balloon been opened up. Now, what can be left from this? Well, you could have an insufficient or regurgitant valve. In other words, blood could go backwards into the atrium, but that's usually a small amount and not of great consequence, whereas the mitral stenosis is. Well, this wasn't done until the 1980s, and the transvalvular replacement wasn't, besides surgery came along in the late 60s, early 70s to replace these valves. But we're not talking about that. That's 30 years yet later. We're talking about 1944. Well, it turns out in 1924, a guy named Cutler devised what's called the finger commissurotomy. Ooh, that's a big word. Commissure is where the leaflets join together on the side. So you got the two leaflets, but they join together on the side like a little mouth, and those will be the corners of your mouth. That's your mitral valve. And those are the commissures, and those are what fuse together and narrow the valve down more and more and more. So if you want to open that, an otomy means to open or to cut, to open up an opening. So you want a commissurotomy. You do a mitral valve finger. You do it with your finger. Isn't this wild? And what they would do is they would open up the heart, open up the chest, and in the left atrium, there's a little appendage off the side, like a little dog ear, called the left atrial appendage. And it was put there for this reason, I think. And so the surgeon would go in there, and that wouldn't be on bypass because there wasn't bypass. And they would cut a little hole in that thing, and they would slip their finger into there, inside the atrium of the heart and down to the valve, and basically use their finger to crack it open. Wow. Now that's major stuff. And it would resolve the stenosis. They may be left with a little regurgitation, like I talked about, but the stenosis is resolved. And I mean, almost immediately, the symptoms disappear. Once they recover from the surgery itself, the heart's now functioning fine again. And all that fatigue and shortness of breath and all those things goes away. Now, this didn't last all that long because it would refuse and the mitral stenosis would reappear, within a year or two. But sometimes people got decades out of this and it didn't refuse and it didn't return. And they did very, very well. So this character could undergo a mitral commissurotomy with the finger. Okay. And then later on, 20 years later, if it recurs, then he could have surgery to open him up and replace that valve. Problem solved. So I think in this circumstance, for this story, the author was looking for a cardiac condition that would limit the individual from doing his job, but could be repaired, and then he quickly returned to normal activity. Well, this fits the bill. So mitral stenosis, we don't see it anymore. We don't see it in this country for sure. We see it in people who immigrate from other countries, Southeast Asia, South America, and all that's where and that's dwindling too. But I remember back when I was in medical school in the 60s and then training in the 70s, well, the only mitral stenosis that we really saw were people who were older, in their 50s. So they were born in the 20s. And usually they had trouble before that, but you'd see them that would survive that long, and then they would be having trouble. And people who came from other countries. If you saw a young person, 20 years old, that had mitral stenosis in 1975, it probably meant that they were from another country because, again, every kid who got the sniffles in the 50s got penicillin, and that wipes out the thing and kills the organism. The immunologic reaction doesn't occur, and life goes on. You had a strep throat. Hallelujah, you're healthy and you're well. Now, obviously, valve replacement became the treatment until these new transcatheter techniques of replacing the valve without going on bypass, without opening up the heart. We the valve replacement. I remember very well back in the 60s and 70s when this was fairly new stuff. And I went to school at Alabama in Birmingham, and it was a major heart center with major surgery because of John Kirkland and Tinsley Harrison and Joe Reeves and Charlie Rackley. The guys that were there were giants in cardiology, and Kirkland was one of the most renowned heart surgeons in the world. So we got a lot of stuff there from all over the world for Kirkland to operate on, and we would replace valves. Well, back then the valves were ball and cage. They were like a little cage with a little ball that popped up and down every time the heart beat. Well, they were noisy, man. They were click, 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 and so you could hear them when you walked into the patient's room after surgery. And you get people who get 3 valves replaced. It was like a symphony. Click, 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 click. And people had a lot of psychological problems from that. And that's just a little aside. That's something that this character may face down the road. Let's say, he gets through this commissurotomy and he gets another 25 years out of it. And now he's in the 1970s, but he's still having problems with because the process has recurred, and now he's got mitral stenosis again, and maybe he's also got aortic stenosis now that the aortic valve has been damaged because the immunologic reaction has already started. It's not going away, and so the damage can go on and on and on and on. So now he gets a double valve replacement, and so click 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 the rest of his life. Uh, then tissue valves came along, and a lot of other things came along, and the whole process changed. So this is a pretty cool question. I really like this. I like the fact, as I said, that it's historical fiction and that it's character driven, and that this person needed some help with some medical issues that they didn't understand, and most people don't. But I think mitral stenosis would fit very, very, very well for his scenario. So I'm DP Lyle, and this has been Criminal Mischief, the art and science of crime fiction. And I'll be back with more episodes before long. And I hope you enjoyed this one and learned something, and something that might help you with one of your stories. Until then.